Thank you for joining Cancer Support Community Atlanta for this program. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. We invite you to sign up for our newsletter to stay connected to all future programs.
Okay, welcome everybody to today's program. Frankly speaking about colorectal cancer. Welcome everybody here in person. We're happy to have you. And welcome everyone virtually to today's program as well. I'm Katie Armsby with Cancer Support Community Atlanta. I'm going to share a little bit about Cancer Support Community Atlanta with everybody in just a few minutes, but I'm excited to welcome Dion with Colorectal Cancer Alliance, who has partnered with us for today's program, and she's going to share a little bit about their organization, and then I will come back in. Everybody, here's Dion.
Good afternoon, everyone. Again, I'm Dion Christopher with the Colorectal Cancer Alliance. It truly is an honor to be here today. Colorectal cancer is truly a passion of mine, been in this area of work for about 20 years. Yeah, good genes, y'all, good genes. With that being said, Colorectal Cancer Alliance has been around since 1999. And it really started when our CEO mother was diagnosed with colon cancer. And at that time, the space didn't have a lot of support. And we originally started as an organization who primarily provided programs for individuals who were diagnosed with colon cancer as well as their caregiver. And so a lot of our programs are going to speak really quickly about what we call as our care pillar, which is all about wraparound service for individuals, caregivers, and patients, and anyone else. And so with that being said, I am part of the screening team, which started about 3 years ago, because we all know that diagnosis is one thing, but also prevention, because colon cancer is a preventable cancer when it is detected early. But and there are quite a few programs there. One particular program that I would quickly highlight out of the screening pillar is the screening quiz. So for those who do not know what your risks are or what your recommendations are, this is a valid, scientific validated quiz by the medical community that you can take and have a recommendation. And it started really in COVID when we couldn't get screenings done, and like a lot of the screenings, we were behind. The care pillar, again, that is where we do really wraparound service. That can go anywhere from our live navigators that are available Monday through Friday, 8 to 5 p.m. And what I love about them is that you dial our 1-800 number, and we really do get an individual who will walk you through whether it's you reaching out diagnosed, you're trying to find resources in your local area, or if you just need someone to talk to. They will recommend you to some online tracks that we have, which again, these are available to individuals who may be diagnosed, going through treatment, or just needing information. And in fact, we all know in our digital age, it's great to go online, but it's also something when you're able to pick up the phone and actually talk to someone. Another wonderful program that I love talking about is our buddy program. We all know that sometimes when you get a life-changing decision and you don't know how to navigate, having someone who is familiar or have a similar path or experiences can be helpful, because you, your family, your friends are trying to figure it out. And with our buddy program, these are actually volunteers who had a similar experience as an individual. It is a national program, and they really go through a vetting service to make sure that whoever, and it could be for the patient or the caregiver, where you are partnered up with someone who you can talk to, and many of them have become really close friends. The last but not least that I think is important is financial assistance, which is what we actually, one of the things we became known for in the health field is that we all know when you're going through this, you may have situations, bills from transportation, utility bills, child care. And through many of our partners, we were able to provide many of our eligible patients a one-time stipend. I think it was like $200, maybe $200 to $300, but it helps them offset what they have to go to. Again, this is patients or caregiver as well. It is national. I'm here in Atlanta, but this is a national program. Last but not least, I'm trying to make sure, because the superstars are coming up, everyone. Just like, the superstars are coming up. And so if I'm talking fast, no worries. Their links will be available, and you are always welcome to call myself or call our 800 helpline for more information. Last but not least, the cure. Cure is simply research. We all know that with colon cancer, it is one of the most underfunded cancers around. Breast cancer leads, and as well as others, which all of them are very important. But again, this cancer is definitely preventable. It is detected and treatable. With that, we've been fortunate to have many opportunities with partners where we've been able to give research awards out to individuals doing research on colon cancer, also biomarker testing, and expanding our clinical trial finder, because that is one of the things that we have also been known for, is that those who got diagnosed, our navigators help them through a partner company to find a clinical treatment program in their area that may be beneficial to them. And with that, Amy, should I turn that over to you? Sure. And I'm sure if you have any questions, just reach out.
Thank you, Deanna. And we'll put links for a lot of Colorectal Cancer Alliance, a lot of the things that she had talked about. We'll put those in the chat box. And for those of you here, you'll have information at your seats as well. So again, I'm Katie Armstrong, Cancer Support Community at Atlanta. Here we have a few pillars of our programs outlined. What I do want to stress today is that we have a colorectal cancer support group that meets monthly, and that's virtually. So if you want to continue today's conversation with a group of people experiencing similar things, that is a great place to go. It is facilitated by a licensed mental health professional. And again, that meets virtually. So you can join from no matter where you are and connect with others. I also want to highlight our nutrition programs that happen monthly. We actually have a couple different nutrition programs that happen monthly. All of those are facilitated by a licensed dietitian with Northside Hospital Cancer Institute. So it's trusted information. And again, that website, cscatlanta.org, we will enter it into the program chat box, but you can click there and see all of the programs offered for free to those diagnosed with cancer and their caregivers. And we have a huge calendar of stuff that's going on. So we invite you to check it out and get connected. And if you ever miss a live program, or if you know somebody who is missing today's live event, we record all of our programs, so you can find them at the video library, and there's a tab for that on our website as well. All right, so just a couple housekeeping things for those attending virtually. We are going to keep you on mute, but we invite you to enter questions into the program chat box, and we'll answer those at the end of the program. And I think that's about it. So without further ado, I'm excited that we have two presenters today, Dr. Satpute with Georgia Cancer Specialist and Dr. Zhou with Georgia Colon and Rectal Surgical Associates. We're going to get to hear from them both today. So first, I'm going to pass it off to Dr. Zhou. Yep, just say her.
Good afternoon. Thank you guys for being here today. We're just going to talk a little bit about the kind of the process when you first get diagnosed with colon cancer screening, and then Dr. Satpute is going to talk a little bit about chemotherapy, and at the end we'll have time to answer whatever questions we want. So, we have no financial relationships or affiliations with this folks today. All this stuff will be kind of just basic objective information. So colorectal cancer, I'm sure you guys have seen a lot of the news recently. It's been rising. It's becoming one of the more common forms of cancer, both in men and women. And not only that, but we've seen an increase in younger patients. Despite the fact that fewer people are dying from colorectal cancer, we are diagnosing more colorectal cancer overall. Colorectal cancer is basically just any cancer that starts in the colon or rectum. We think that what happens is over time with aging or genetics or environmental factors, your colon grows polyps. And at some time, those polyps keep growing, and then they turn into a cancer that then needs to be treated, which is why it's so important for people to get screening exams, whether that be a blood test or a stool test, or the best way is the colonoscopy, to find these polyps and get rid of them before they become cancer. But if you wind up in our office, because you're having abnormal symptoms such as bowel movements, blood in the stool, abdominal discomfort, weight loss, we will do that workup to hopefully make sure that you don't. To find out if someone has colon cancer, number one, we see them in the office. see if they have any abnormal symptoms like I talked about. And then the best test on here is a colonoscopy. What that is you take a wonderful bowel prep, of course, the day before, flush out, and then on the day of, you get a nice little nap, we look inside your colon, and if there's polyps, we take them out, and then if we find something scarier, we always let the patient know. After that, we can get blood tests or scan and talk about whether or not you need surgery or chemotherapy to treat anything with violence on those testing. Once you're diagnosed with cancer, we send out a bunch of tests. You guys don't have to remember this, but this is important information, especially for Dr. Satpute, in titrating people's chemotherapy if they do develop colon cancer. And so all of these words like tumor markers and genetics are going to be part of your vocabulary when you're first diagnosed with colon cancer, which I know can be very overwhelming. So step one, you come into our office. If you're diagnosed with a new colorectal cancer, I tell patients just breathe. I know it's overwhelming. You're going to get a lot of information, and then we kind of try to map out what's going to happen next. So first, we have to find out, after you're diagnosed with cancer, how advanced is the cancer? Is it just in your colon? Has it spread elsewhere in your body? And that'll basically put you on a different pathway for treatment. In order to find out these things, people will get some CT scans to look at these things, as well as sometimes they'll get special ultrasounds to see how. This is just a fun picture to kind of look at, how cancer can get bigger and bigger, and then as it gets bigger, it gets more, I'd say, people more aggressive, and then it can start spreading other places. So once you're diagnosed with cancer, we do the workup, and then suddenly you're given this whole list of other people to see, including not just myself as a surgeon. You'll see an oncologist, whether that be a chemotherapy doctor, sometimes you go see radiation doctors, suddenly lined up with all these other assisted people, and we have oncology nurse practitioners, social workers that help you navigate the system, a nutritionist, and then we help people with GI, we call our GI navigators, to help when you get this list of 10 to 15 people suddenly you have to see. And then of course you always have to go back to your primary care provider, if you're a medicine doctor, and tell them all of the things they have. But this is what usually comprises of your healthcare team for a new colon cancer diagnosis. I tell people the first appointment is always the most overwhelming. I give them lots of information, they take notes, and then as a patient, go home, digest, make a list of more questions. Don't be afraid to make multiple appointments with your practitioner to come back and ask questions. I think that's really important because there's so much to know about colon and rectal cancer, and we as medical professionals are still learning every day, and we go to, decades-long school to learn all these things. So I totally get it when people, having that 15 to 30 to 60-minute time in the office is not always enough. Go home, write down your questions, do a little bit of research, but not too much on Google, and then come back and ask more questions. Tell us, take the time to tell us what's going on with you during this journey, because I can't read your mind. So if you need someone, you need a support group, ask us. If you're feeling depressed, let us know. If you're having pain or bleeding or things that you weren't having before, make sure you share that with us so you won't be able to know. And we can always make adjustments into your visits and your treatment if that's the case. And then this last one's my favorite. Bring a friend or relative. Whenever I get a new cancer diagnosis and I have to tell a patient on the phone, I tell them, listen, we're going to go through a lot of information. Try to bring your friend or family member who can come help take notes, because they will absorb different information than you do, and they'll help ask questions for you and write notes while you can kind of maybe sometimes you can just listen and they can do all the writing, and then you can go home and compare notes. I think that's always helpful. And my other favorite thing is when my patients come in with a whole binder of all of their information. And it's so funny because they're always embarrassed about it, but I love it when they come in with a binder. They know their whole journey, they have all their stuff. I think it's good for you guys, for people to be organized. So don't be afraid to bring that binder over to the doctor's office. It's totally okay. And then, of course, as we know, everyone has different personalities. You're overwhelmed. You want to hear things in different ways. I can tell you that I'm never offended if somebody wants to go see someone else for a second opinion, even a third opinion. That's totally okay. We know different personalities don't match, or you want to hear it a different way. You want to have someone closer to home, do it. You know, this is your one chance to get that information. If that's something you want to do, don't feel like you're going to hurt our feelings if you go somewhere else and ask for more information. Okay? All right, so that's all of the frou-frou stuff. And then, so now what happens when we're figuring out your treatment? So number one, we figure out where your cancer is, how bad is the cancer. We look at all those tumor markers I mentioned before that get sent off. And then we kind of review who you are as a person. How well are you going to tolerate our treatment options for curing your colorectal cancer? And then we talk about the risks and the benefits of the different types of treatment options. And then as a group between you and all of the physicians involved in your care, you decide ultimately what treatment course you're going to take. So that's why it takes sometimes multiple visits, a couple weeks to finalize these decisions, which is okay, but don't take too long. Our goal, of course, is to cure people of cancer. But we know realistically that some people come in with the cancer too aggressive or too advanced. And so then we start talking about how do we keep the cancer at bay enough so that you can live longer or have good quality of life. And Dr. Satpute will talk about some of those palliative support groups we have to help people on that journey. And I think both of these are important. And I think sometimes it's scary to talk about not being able to cure cancer, but there's a lot we can do nowadays to help people, you know, on that road of kind of managing their cancer symptoms and buying more time to spend time with family and friends. Once we figure out what our goal is, here's where all the doctors come back, right? So we talk about, should you have some sort of surgery or some sort of chemotherapy or radiation or combination, or is your cancer kind of weird and we've got to put you in a clinical trial? And so that's where all of these different treatment options can come into play. Today, I'm just going to briefly talk about what surgery entails, because I'm a surgeon. So usually our goal, if you're a surgical candidate, is to remove your colon cancer by either little incisions, which is called laparoscopy, or robotic surgery. Sometimes people have lots of scar tissue or their cancer is really big and they end up with a bigger incision to remove the cancer. But our goal is to remove all the cancer and not have anything left in your body that we can see. Sometimes because of it being your colon, which is an important structure for moving your digestive system, we have, and depending on how sick you are when you come in or where your cancer is located, some people get what's called a stoma, which is a colostomy or ileostomy, where you get a poop bag on your belly that basically instead of pooping and coming out of your bottom, it comes out into a bag on your belly. This is one of the scariest things for patients, I know, because it's abnormal, they get embarrassed, but honestly, what I try to reassure my patients is it's really not that bad, and you probably know somebody who has the bag and you just don't know it because you're just hides under their clothes, and there's no restrictions. You can still go on roller coasters, you can still go running. There was like a Sports Illustrated article several years ago that had a bunch of bodybuilders kind of talking about being bodybuilders and having a stoma. So I think, you know, now with all of our great resources, we're seeing a lot more of people kind of talking about these things, which I think is really helpful. But that's kind of the nuts and bolts of surgery. And then when you come and see a surgeon, we talk about, you know, recovery from surgery, weightlifting, and then ultimately we want to get people onto the next step, which is either cure or potentially chemotherapy. So I'm going to hand it over to Dr. Satpute to talk about the next part of the cancer journey for patients.
Thank you. Thanks for this opportunity. I'm a medical oncologist. My name is Dr. Satpute. As a medical oncologist, I wear many hats. We are involved in cancer care in multiple ways, and this chemotherapy is just one of them. When I was in training, one of my mentors, Dr. Georgia, told us what a real medical oncologist does. And what we do is we always strive for cure for a cancer. But if we can't cure a cancer, we can always treat a patient, treat a cancer. Now, what if we can't even treat a cancer? We can always treat a patient. and that is the philosophy of any medical oncologist. There is no one that we cannot help in cancer world. So, what is a chemotherapy? So it's basically a medicine, a chemical that's given to you either in an oral form or injectable form that goes into your body all over, not just the cancer area, but all over. The way the chemotherapy works is that it's basically a toxin to DNA, and anything that grows fast as their DNA expels. And I know this is kind of an oversimplification, but just to help you understand what this chemical does is anything that has the DNA exposed, the cancer is going to try and attack it, and that's how the chemotherapy attacks the cancer cells, which are the most actively growing part of your body, attacks preferentially compared to the rest of your body. However, there are parts of your body that are still growing, and that's where the side effects come from. So the treatments in terms of chemotherapy are heavily stage dependent. For example, stage 1 of colon cancer, you don't need chemotherapy. You just get a surgery and you're done. Whereas if it's a advanced stage, you do need chemotherapy. There are chemotherapies that are given before surgery, and they call it called neoadjuvant. They're typically the case in rectal cancer, whereas there are some that are given after, typically in colon cancer. These are some of the listed chemo drugs here. Some of these chemo drugs are IV and some are oral. For example, this capecitabine here, the second drug here is the pill. Even if it's a pill, it's very much a chemo. We'll talk about the side effects. Over the past 30 years, they have done incredible research in cancer, and they've come up with some non-chemotherapy options. Now, unfortunately, as it stands today, all these non-chemotherapeutic options are still limited to stage 4 colon cancer. We do not have any indications or immunities in early stage. The reason being that these are very effective and definitely milder than chemotherapy. However, their effect is not as robust and has not been proven to be beneficial in early stage. So I've just given this picture here to help you understand all the research that has gone into discovering these drugs. So all these molecules have been discovered over a period of time, and they've realized that these chemicals, these proteins kind of work in cascading fashion and eventually stimulate the cell growth. And the role of these medications is to really specifically attack one of the two pathways and keep those cancer cells from growing. So we have a number of listed agents here. So, like I said before, the chemotherapy still exists only because the chemotherapy is still somewhat more effective in certain scenarios than these medications. But there is a chance that eventually we might be able to get rid of chemotherapy and maybe just resort to some of these agents that are very specific. And there is a very bright future to cancer therapy as a result. So what are some of the side effects? So the chemotherapy, you may have heard of chemotherapy causing certain issues, and the philosophy there is, like I said, the chemotherapy is not a very smart drug. It goes and attacks anything and everything that's trying to grow. For example, your hair follicles are growing every day. So that's the basis of having hair loss. Now, typically, some of the initial treatments we use in colon cancer and rectal cancer are actually milder. The chemotherapies don't necessarily cause hair loss, but it can cause some of these other symptoms. It can give you diarrhea. It can cause the cold sensitivity. We call it peripheral neuropathy. Fatigue, of course. The nausea. Nausea is about 20% prevalent in chemotherapy. Used to be about 100%, but we've come up with this incredible regimen to prevent nausea nowadays. So people, when they come to me talking about chemotherapy, their first question is, am I going to suffer from this? What about that nausea? Because they have seen their family members suffer through. And I tell them that we've come a long way compared to several years ago. And there is only a very little chance that you might actually have to suffer. And even if you have nausea, we have plenty of medications that can alleviate those. So even though these side effects listed, actually the reality can be a lot easier and better for an individual. So what about radiation? The radiation doesn't have a lot of role in colon cancer, but it does in rectal cancer. It's the rectum is this bottom part of your colon that is actually fixed and very much in the back of the pelvis. And because it's fixed and not movable, the radiation makes sense because radiation is a very focused treatment that's given to certain areas. And because the proximal bowels kind of move, you don't want to be radiating those because you don't know what you're radiating. But the rectum is. And when you get this treatment, it's supposed to effectively control the cancer in that particular area. But as a side effect, it can give you some skin burn. What it is really this high energy rays that gets focused into that particular area, and it's in its pathway, it can give you some skin burns, pain, swelling, incontinence. And we'll talk about some of these other side effects later. What about chemoradiation? Sometimes it's necessary to do both the chemo and the radiation together in order to get the biggest and the best effect. And that particularly applies to rectal cancer rather than colon cancer. Immunotherapy, this is a new avenue. This got discovered in 2002. And we have come a long way in trying to understand this. This is not a chemotherapy agent. It basically goes to your immune system and tells your immune system to fight the cancer. What we did know about our immune system for many years is it's not just meant to fight infections, but really keeps you away from cancer. So they've come up with these very specific pathways in the immune system, the PD-L1 and CTLA, that are targeted. And when you target these pathways, they stimulate that type of immune cells that can fight cancer. Unfortunately, most of these immune mediated treatments are not a mainstream in colon cancer because they've done the studies and it's just not one of those cancers that respond to immunotherapy unless you have the mutations that are listed here. And those are somewhat rare, but if you have it, then the immunotherapy works wonderfully. So how do you manage the side effects? Remember that you're not alone. Whether you're with a surgeon, you're with a medical oncologist, radiation oncologist, we're not just one individual. We work as a team, and a lot of team members actually have incredible advices to give you. For example, if you are at a infusion receiving chemotherapy, the infusion nurse can actually tell you what to expect and how to alleviate some of the usual side effects that we previously discussed. One idea about preventing or treating side effects is really to address them even before they're about to happen. For example, I told you about the nausea medication. We're able to prevent nausea better than we're able to treat nausea. So that's why we give nausea medications beforehand, about 30 minutes before any chemotherapy. And that works much better than treating it as an afterthought. Same thing applies at home. If you're about to get nauseated, you don't wait until you start throwing up because then you can't keep the nausea medicine in. You have to start taking it soon. If your blood counts are low and you start having fever, we advise people to go to the emergency room or come to the doctors immediately before the infection gets ugly. So these are the ways you can work on these side effects sooner before they get really ugly. There are issues with bowel when you have colon or rectal cancer, because after all, this is a cancer of the bowel. So you may have already had a surgery, so part of your bowel is removed. So just by the virtue of having part of your bowel removed, your bowel habits have changed. On top of that, you get chemotherapy, and those certainly do affect your bowels further. So you could develop nausea. We talked about that before. You can have abdominal discomfort, bloating. You could either get diarrhea or constipation. And really, when a patient comes to me, I really tell them, I can't tell what's going to happen to you. It could be one or the other or nothing. Oftentimes, people, I inform them about diarrhea from chemotherapy, and they say, I haven't gone in several days. So really, you have to kind of be vigilant about your own symptoms and act accordingly. Of course, if you have constipation, you get the laxatives, you have diarrhea, you take medications to alleviate that. These scary processes do happen every once in a while when the cancer is very big, when it starts or gets discovered. A lot of patients show up with their bowel perforated, and then Dr. Zhou's team has to go in and actually work on that before anything else can happen. But some, even the chemotherapy drugs, are known to be responsible for causing perforation. So this can pretty much happen at any point, but know that this is not that common. Clinical trials, the patients are always afraid of clinical trials. They think that am I going to be a guinea pig? But you should realize that clinical trials are in patients' favor. The person that benefits the most from clinical trial is the patient. Why? Because nowadays the clinical trials are extremely ethical. We never give patients something that is not standard of care. What we do in clinical trials is a standard of care which is given to everybody, but we do something on top of that as an experiment. So if for one certain condition there is a drug A given to everybody, the experimental group gets drug A and drug B. The B is the experiment. And so remember that it's always in patient's favor. And then also, this is not a one-way street. If you want to leave the trial, you can leave it at any time. So I always encourage people to ask for clinical trials. So how do you follow up after you're done with colon cancer or rectal cancer? Initial treatments. So this is called surveillance. So this involves you go to the doctor every 3 to 6 months, you get your blood check, you get CT scans every once in a while. Typically, we do CT scans once every 6 months to a year in colon or rectal cancer. And then at the end of that first year, before the year ends, after you were diagnosed, you should get one colonoscopy. And then as for the gastroenterologist, you should continue getting colonoscopies done. So how do you cope with colon and rectal cancer? This it is that's a major role that the cancer support community plays here. But one of the things I want to emphasize is the palliative care. So there was a wonderful article that came out about 4 or 5 years ago that looked into the role of palliative care. So palliative care is basically a science that looks into how to alleviate patients' suffering when they're going through cancer diagnosis and the treatment. And it's not a stage-specific approach. It could be offered at any stage, but it is incredibly beneficial. So that study showed that the patients that were referred to palliative care team early on, at the really very start of their treatment, had actually better cancer outcomes than those who were sent toward the very, very end of their treatment, toward the end of their life. So I think it has a very objective benefit. So palliative care. So what palliative care is basically addressing your symptoms and really work on alleviating the symptoms rather than the cancer treatment. So it certainly is an important aspect of cancer care. We focus on quality of life. There are certain times when cancer is early stage. We say, okay, we're going to do everything we can to cure this. And so in that situation, we are able to offer patients a little severe treatment that can cause compromise in their quality of care. But when it comes to advanced stage, we have to focus because we know that the patient is going to live with cancer for the rest of their life. And in that case, quality of life is extremely important. So it is both physically and emotionally challenging to go through the treatments. And we have to address both So let's go through one of each of these. So anxiety and depression. So you have to ask yourself these questions. Do I worry constantly? Am I able to sleep? Um, and here you have to ask, do I feel sad all the time? And all these symptoms are very, very common. Unfortunately, a lot of times these get ignored. In fact, most of the patients who are about to start on chemotherapy, a lot of us fail to actually address that or ask patients, how are you feeling? And if we don't, we never find out what these symptoms are, and we never are able to address. Um, so it is important for the patients to really identify these and really come out and tell the doctors. Sexual health, it is definitely affected throughout the treatment that has the emotional implications as well as physical. Fertility, the fertility, as Dr. Zhou pointed out, the colon cancer is happening more and more in young patients, and then the fertility has become a major issue. So we always ask patients when we're about to start cancer therapy, would you like to see a fertility specialist or in case of men, sperm donation and things like that to really preserve the fertility. But remember that there's not always enough time to address that when there is an impending issue that needs the treatment started sooner. We usually offer that, and sometimes patients choose to just go ahead and start the treatment. Support groups are very, very important. And it's important because you learn from other people's experience. And there are incredible support groups through cancer support community that would provide just that. So you learn from others. You can share your experiences. You can cope better knowing that other people are in the same boat. And then all those emotional issues are also better tackled when you are in company of someone who's in the same boat. So when you are part of a group, it is known that it decreases. There is decrease in the depression, depressive symptoms. There is increased zest of life, new attitude. So there are different strategies of wellness, physical activity, eating, drinking better, and creating your own individualized plan. And you can actually see here, this chart shows exactly all those points. One of the most ignored groups in cancer world is the caregivers, and we don't really realize how much they suffer. And it's because they kind of get behind the curtain and their suffering never gets addressed. So I think a cancer support community and organizations like that certainly are capable of recognizing that and able to offer a support to the caregivers as well. Practical aspects, cancer care is very, very expensive. And if not done in the right way, it can certainly create a huge financial burden to patients. So there is a lot of support available in that regard. We recommend patients, like every other individual, really, we recommend patients to act early, even if you don't have a cancer diagnosis. Be prepared, because these things don't come to you with a warning, they just happen. And so it is important to consider a will, a healthcare proxy, name someone in your family or your friends, assign them to make decisions for you, and so on and so forth. And these are some of the resources. Sorry, I hope I didn't go over here.
No, I think you're great. So I think now, if you're joining us virtually, we do invite you to enter questions into the program chat box. And we'll get started. We do have a couple to jump to, and of course, if you're here with us in person, we invite you to ask questions as well. One of the questions, and Dr. Zhou, this might be for you or tag teamed. One of the questions is, how do you determine if you are a candidate for surgery?
That's a great question.
Oh, yeah,
Great question. So when I meet somebody in my office to decide whether they're a surgical candidate, first I want to know how active you are at baseline, which we call functional status. Can you walk a block? Can you walk up a couple stairs? Are you exercising frequently? Even if you can't walk very far, that doesn't mean you're a surgical candidate. It just helps us have a better understanding of what we call your risk profile. We also want to know what medical conditions you have and what medications you take, because we know that certain medications and certain diseases make you someone who doesn't heal well. So if you lost a ton of weight and you're malnourished, you're not going to heal as someone who's been, eating excessive calories and have plenty of extra, weight and fat to burn while they're recovering. Or diabetes or smoking can also compromise your healing. And then finally, I also want to know what other surgeries you've had in your belly, because going in there a second, third, fifth, sixth time is certainly more different than going in somebody's belly who's never had surgery. So all of those combined together, I will sit down with the patient and we'll talk about, this is you. These are your risk factors for either not healing well or having complications during surgery. And this is where I think you will land. Are you going to be someone who gets out of the hospital in 2 or 3 days because you're so robust? Or are you someone who might stay in the hospital for a week? Are you someone who needs to go to rehab afterwards to get healthier? Are you someone who I think I can connect your intestines back together because I think you're going to heal great? Or are you someone who's going to get a temporary stoma? So most of the time, patients can get to surgery, but we have to talk about what is your recovery going to look like and what kind of complications are you going to be at risk for, and kind of what statistical way, like is it going to be 5%, 10%, 50% chance that would happen to you? And then after we kind of talk about that, then you and I make a decision of like, are you willing to undergo those risks in order to either cure your cancer or treat yourself?
Thank you. And this question, I think, goes along with that. How do you determine if you do chemo before surgery versus after? Kind of what makes that decision?
Great question. So we decide whether to do chemo before or after surgery based on how advanced your cancer is and where it's located. Like Dr. Satpute was talking about before, rectal cancer has found to respond better to what we call neoadjuvant therapy, which means chemo or radiation up front, which can sometimes help shrink the cancer and help your chance for cure be higher, versus colon cancer, typically, unless it's spread to elsewhere in your bodies, typically will get upfront surgery followed by chemo.
And we did get a question. I think Dr. Satpute, you talked about immunotherapy kind of being rarely used with colorectal cancer. We got a question, do you know if there are any clinical trials trying to advance it as an option for colorectal patients?
Yeah, so a lot of clinical trials have already been done to see if immunotherapy has any role in colon cancer in early stages, and it turned out it was not very effective. They always compare with what standard of care, like I said before. So they're seeing that it wasn't really any better. So there is that, but there is definitely one indication where if you have the mutation that they found, if you have this phenotype, they call it mismatched repair enzymes, if they're defective, no matter what stage you are, those patients do benefit. But outside of that, they really haven't been able to. But there are incredible amounts of, we have about 7 or 8 immunotherapy drugs that are currently available. So there are 7 or 8 sets of clinical trials being performed in all types of cancers, colon and rectal included. So the answer to that question is yes, there is ongoing clinical trials for colon and rectal cancers to go.
Do you guys have any questions in the audience?
Actually, I do. So, so you were Georgia Colorectal surgery. Well, not this. I'm familiar with that place because my dad went there many years ago. So, Back then, my dad actually went there for a colonoscopy, so do you do colonoscopy and colorectal cancer, do you both type of thing, or?
Yeah, that's a great question. So most colorectal surgeons will do colonoscopies as well as treat colorectal cancer. There's a lot of need for people to get their colonoscopies, and unfortunately, not enough providers. Even with GI surgeons and colorectal surgeons doing colonoscopies, so all of us will typically schedule patients, even for screening colonoscopies in all of our centers, because there's plenty of people who need it, and we just don't have enough time to address it all. So none of us are feeling like we're fighting over patients to get, colonoscopies done. So you can go anywhere for your colonoscopy, which is great.
It's not a follow-up question, because I recently had a colonoscopy done myself. So there was a polyp discovered, but apparently it was really, really small. So I'm curious, thankfully it was discovered, but how likely are these things going to be all discovered? Because I'm sure there's going to be a rate of missing some of them, right? So what is that rate of missing some?
So the proposed rate that we tell people of missing polyps that people have in their colon is a couple percent. We say that the sensitivity.
So what I heard?
Yes, a couple.
Mhm.
It's different based on your literature. You see somewhere between like 1 to 4% is what people quote in the literature.
Mhm.
But the ones that are typically missed are very, very small. And typically people will come back for a repeat colonoscopy if they have any polyp, at least at that 5-year mark. We think that in general, it takes about maybe 3 to 10 years for a polyp to develop in a cancer. Most of the time, more along the 5 to 10 mark for like what we call a traditional precancerous polyp. But we also know that some patients are more at risk to develop more aggressive polyps, or if they have like inflammatory bowel disease or genetic disorders, their pathway that Dr. Satpute shows you from mutation to cancer growth evolves faster, or maybe along a different pathway that we're just still learning more about, which really helps us try to guesstimate your interval for a repeat colonoscopy. But it's not perfect. It's great. I still can tell people to do it because I think the miss rate is very low, and the potential to catch things and prevent them from growing outweighs the risk. But it's not perfect for sure.
Because I wonder though, sometimes if the prep is not done very well, because some people I've heard from my friends, colleagues, their doctors will know prep was not that good. That's what they were told. So I wonder if the prep was not done very well for whatever reason. I mean, doctors are human too. I mean, I wonder if that could have been missed.
So we, whenever we scope someone, we will document whether they had adequate or inadequate bowel prep. Mm-hmm. And if we get in there and the prep is not good enough, people will typically be asked to come back sooner for the colonoscopies. And that's the other great thing about, evolving in medicine is that there's actually more options for prep nowadays than there used to be. And some of them are much better tolerated than the traditional that we were doing 20 years ago, which helps, but obviously everyone's colon is different. So everybody kind of has to find the right prep for them. But certainly if you don't have a good prep, you're told by your colonoscopist to come out.
I have one more about here.
Mm-hmm.
So I know of, for instance, a person that a colonoscopy done and was told that he looked good, but a year later came back with stage 3 colon cancer. Mm-hmm. So how could that be possible?
So great question. Some people come back sooner than we expect with aggressive cancers. We don't always know why. Like you said, there's always a small risk that we miss something, but usually if it's that aggressive, we think that there's something genetic underlying, or maybe they were treated for something else that compromised their immune system that caused all of the cells in their body to mutate differently. We unfortunately don't know. And we do see that subset of patients. Hopefully we'll know more in 20 to 50 years.
Yeah. And is there a physician named David Armstrong still in practice?
He's not with our group anymore.
This question kind of goes along with what you were mentioning, genetic. There was a question in the chat box. What is the role of genetics with colorectal cancer, and how does that affect kind of best screening practices?
Yeah, sure. So there is a set of inherited syndromes that can make you prone to colon cancer that can run in family. For example, there is one syndrome called Lynch syndrome, and that the patients who have those mutations, they cannot get passed from one generation to another. And all those people actually have a higher risk of developing colon cancer, among other cancers too. So that is one way of looking at it in terms of genetics. But even if you don't have the mutations can happen to colon cancer to that individual in that particular tumor, even though the rest of your body or your genes don't have it. And that's called somatic mutation. And that can happen, and that may be to your benefit though. So for example, if there is one mutation called BRAF mutation. So just 3 years ago, they did a study with oral drugs. They found out that patients who have BRAF mutated colon cancer actually respond to just the oral therapy. And so they can forego chemo and just be on oral medication and still have almost equivalent response. So some mutations are in your favor, some are not.
And I think there is one more question. I'll check the chat box, but after two, how often, or I guess what determines if you have to have a permanent ostomy bag?
That's a great question. So what determines whether or not you end up with a permanent ostomy bag has to do with the location of your cancer, your functional status. We talked about how robust are you going to recover from surgery. And sometimes if patients, even if they can be reconnected together, maybe they have a little bit of baseline incontinence, or they have a very active lifestyle where even if I do connect you back together, you cannot, do all the things you want to do because you can't manage having 4 to 8 bowel movements a day. And so that's really a discussion about your specific case. But the most common reasons are a cancer that's too low, that's involving your anus muscle, because that muscle is important for maintaining your control of pooping. And if we have to get rid of it, you're not going to be able to control. Someone who comes in really weak, malnourished, older patients who are wheelchair bound do better. Sometimes with a permanent stoma, and then sometimes just based on, even if you get reconnected, if you're miserable and come back, some people just end up with a permanent stoma. But like I tell everybody, it's not the end of the world. Have a stoma. You can still do all the things that you want to do. There are really actually few restrictions. It really just changes where your poop comes out of.
I think that's it for the questions in the virtual chat box. I want to thank you, Dr. Satpute, Dr. Zhou. Thank you so much for being here today. I will remind everybody there's going to be a recording of today's program on our website at cscatlanta.org. So if you know someone who missed it, feel free to kind of send them there where they can find it. And also we have some evaluations. I've entered an evaluation link into the chat box, and we have some evaluations to pass out today too. If you could share your thoughts on the content of the Frankly Speaking program so we can keep these tailored to be pertinent to the colorectal community. But thank you both again for being here, for sharing such valuable information. And we hope to see everyone again soon. Thank you.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.